For those that don't know me online, I'm Mike. I'm one of the Echo Fellows here at St. Mike's. I did the majority of my cardiology training at McMaster, and then last year did heart failure and transplant at Toronto General Hospital, and here for the next year doing Echo to consolidate everything. So today we're going to be talking kind of more about a bit of a niche topic, but I'm going to try to make it as generalizable to everyone online. The majority of the talk is actually going to be going through kind of just some of the principles of both mechanical circulatory support, as well as the importance of measuring RV function, why we measure RV function. Oh, hey, Dr. Chow. And why it's important essentially in this patient population more so than anything else. Okay. And so we'll start with explaining the pathophysiology of RV dysfunction in patients on mechanical support and why it is important for their outcomes. We'll kind of review standardized RV assessments and then specifically look at how this applies to this particular population. And then I did a bit of evidence review for essentially looking at echo predictors for if we can risk stratify people into more high risk, low risk, things like that. And so I know that not everyone on the call or in the room today is as familiar with mechanical support. And from my understanding, I think this will be a growing field at St. Mike's Hospital. A lot of the tertiary cardiac centers are now getting involved in this field. And so essentially different forms of mechanical support are being increasingly used in people for the management of patients with cardiogenic shock, both ischemic and non-ischemic. And essentially the principle is that in patients that are very sick and not responding to medical therapy, we can use a variety of devices to essentially support or even bypass their heart while they're waiting to recover. And so the goal is typically recovery, but sometimes these patients don't require or accrue multiple complications where we actually they actually can't survive with their native heart function. And for those people, we actually look for more long-term, essentially, strategies to support their heart. Sometimes being a mechanical heart that people can go home with, and other times people go for heart transplant. And so echo is really like a cornerstone and very critical in evaluating these patients over their entire trajectory. So it matters pre-implant, post-implant, during implant. If we can get it away, we need to escalate to further intervention. And I know that you guys had a very excellent talk in June that kind of described all of the importance of using echo in this patient population. And so this is a very chaotic diagram that I kind of organized last night, but it's meant to kind of illustrate that every patient is kind of unique and there's various pathways that patients can follow. And so when a patient arrives to hospital, is very unwell, is being considered for mechanical circulatory support, the left part of the screen is the temporary devices that are really used in Canada. There's other ones I'm not going to touch on because they're not really commonplace in Canada. But we have our temporary types of support to initially stabilize these patients. So one being an Impella, which is a motor that's put in the left ventricle, and that's inserted through the femoral artery in the cath lab typically, and placed essentially in the left ventricle, and it takes over the function of the left ventricle and essentially sucks blood out of the left ventricle and pumps it into the aorta. So the left ventricle doesn't have to do any work, it essentially rests. The other form of mechanical support is ECMO, where we're actually taking blood out of the body from the IVC or SVC, and we suck all that blood out, and we essentially bypass the heart completely. Suck the blood out of the body, it goes through a motor and an oxygenator outside of the body, and then it pumps blood through the femoral artery up the descending aorta, retrograde to the heart. So it's almost like a dialysis machine in sorts where it's actually bypassing the organ of interest completely in the form of VA ECMO. And there's a number of kind of clinical considerations for why you go for one or the other. And I'm oversimplifying it a bit, but two of the most important considerations up front are how many ventricles do you need to support? Is it just the left side? Because if it's just the left side, we may be able to get away with using an impella. But if both ventricles are not working, we can't just support one side for reasons that we'll outline in the next couple of slides. Because we need both ventricles to be supported. And so for that situation, we typically go to VA ECMO to completely bypass the heart. The other one that's kind of on the back burner that we won't talk about too much today is the oxygenation status of the patient. Does the patient need oxygenation? Because again, with an impella, you're just reliant on their own lungs or ventilatory strategies. If they need peripheral oxygenation in the form of ECMO, that's another determining factor. Now, once you're in the temporary kind of stage, both of these devices, there's varying time limits that you have, but once a device goes in, we always think basically the next 30 minutes is how the heck do we get this out of the patient to prevent complications that accrue over time. And so a general timeline, just for people that don't have much experience with these devices, is that they can really only be in for like days to weeks, really 14 days kind of max for VA ECMO before you start accruing complications. It's a foreign device in a patient. Patients develop infections. They have problems with bleeding because they have to be anticoagulated. It's a motor in the body, sucking blood out. You can run into problems with hemolysis, breakdown of red blood cells, things like that. And acute kidney injury, those tend to be the most common things that we run into. And so as mentioned, the goal is typically recovery, but if patients don't recover, we have to think of something more what we call durable. And when I say durable, it's that we're kind of outside of that 14-day timeline. We're able to get them to some type of support where hopefully we can minimize complications and patients can actually leave the hospital. And so again, in Canada, there's a couple of different durable support options. One being what we call CentraMag devices. That's the one in the middle where it's essentially external motors outside of the body that, again, bypass the heart. It's more stable than ECMO because it's not using the legs. It's a surgical procedure where we take blood directly from the heart and pump it back into the aorta. And so patients can be in the ICU on these devices and they can actually get up and walk around. So you can imagine on VA ECMO, with your legs being confined for access, you can't get up and walk around. So this device is used to buy time for people, and you can be on this device for a couple of months actually. And you can walk around, kind of rehabilitate in the ICU while you're on this. Now you can't leave the hospital on this device, and you can't actually leave the ICU on this device, so it's not a durable in terms of long-term strategy, but it essentially can buy time while the patient is either recovering or we're deciding for more long-term support where they can leave the hospital. And that leads us to our two next options, which is what's called an LVAD, or a left ventricular assist device. And this is in the top right corner. And then this is essentially a motor that people can go home with. So there is a large motor or cannula in the apex of the left ventricle that sucks blood out through a graft that then goes to the top of the aorta. And it's essentially powered by batteries. And so people have a little drive line that leaves just under their diaphragm here, and they wear batteries almost like a Batman pack. And they have batteries attached here. And this allows people to kind of carry on their day-to-day lives. They can't go swimming, that's one thing, but you can shower. And this allows people to leave the hospital and recover. Now, importantly for LVADs, similar to some of the devices that we talked about here, LVADs only support the left side, right? It's a motor in the left side. It does not support the right side at all. And so this is an important consideration in people that have right ventricular dysfunction. The other option, of course, is if you have biventricular dysfunction or a number of other kind of clinical characteristics that we won't get into, is that patients can go for heart transplant. So get rid of the old heart, put in a new heart, and that's how patients kind of get into hospital. Bit of an oversimplification, but those are kind of the general kind of pathways or treatment decisions that lead to kind of escalation of these devices. And so I just wanted to highlight that throughout this process, and specifically what we'll be talking a bit about today, is that assessing the heart, in particular the right ventricle, in particular, becomes very important because it does play a big role in deciding if patients are a candidate for one or the other. And the more options you have, the better. But also selecting the right device for the right patient is really important. Okay. So when we think about kind of problems with the right ventricle or pathophysiology, it's helpful to just go back a couple of steps and really start with the anatomy to understand that why the right ventricle is different than the left. And so the right ventricle is a much more thin-walled structure. It has much less muscle mass than the left ventricle, and it is really able to accommodate volume but not pressure for that reason. A large proportion of the right ventricular function is based on the longitudinal forces when it contracts downwards, essentially. And it relies a lot on the septum to actually generate that. So it needs like a stiff septum, robust septum from the left ventricle to essentially provide scaffolding support so that it can contract longitudinally. And so this is usually the first kind of motion of the right ventricular wall when it's contracting. And this is how we look at the TAPSE and the S prime as kind of surrogate measures of this longitudinal contraction. And so because the right ventricle really relies on this septum for support, it is very intimately associated with the left ventricle. And we call this relationship ventricular interdependence. And so it relies on a high pressure in the left ventricle and a low pressure on the right ventricle to essentially have this normal septal motion so that it can contract normally. And this relationship is described through something called the transeptal gradient. And overall, this gradient is actually responsible for pretty much 40 to 50% of RV contractility. So it really relies on this gradient. The other thing that's important in right ventricular hemodynamics is the pressure that it sees. And so the right ventricle is pumping against the lungs as opposed to the systemic circulation of the left. And so it really, really likes a low pressure, calm lung system where it's not needing to generate a lot of contractile force against a high pressure system. And so when we take everything in combination, it's very preload dependent. It can accommodate volume and really serve as a conduit to get blood to the left side of the system, but it really can't accommodate distortions in the interventricular architecture, but also high pressure in the lungs. And so there's been lots of animal and human-based studies that essentially have evaluated what happens when pressure goes up in the lungs or this transeptal gradient is abolished, and essentially it leads to a lot of hemodynamic alteration. So once the pressure increases in the right ventricle starts to balloon outwards and have a rise in pressure, the blood flow to the left side is reduced. The pressure in the left ventricular cavity is reduced, and this septal architecture essentially becomes distorted, which leads to this vicious cycle of RV dysfunction. So you can see how once things start to go awry, the RV is not very adaptive and tends to make things worse with how it changes, essentially. And it leads to essentially a vicious cycle of RV dysfunction. And not only is it a vicious cycle, but it's a quite precipitous cycle. And so you can see that as pressure rises, the right ventricular stroke volume essentially precipitously decreases, whereas the left ventricle can kind of hang around for a while and accommodate rises in pressure. And again, once these changes go into motion, decreased left ventricular filling will decrease cardiac output, which then worsens perfusion, ischemia, all things that the right ventricle then has to combat with and is not really able to accommodate very well.
Michael, what about the rapidity of rise in RV pressure or pulmonary hypertension, sort of acute versus kind of chronic?
Yeah.
That a little bit?
Yeah, and so essentially as Dr. Leon Poy is pointing out, is the delta change like over the acutes is much worse than over long term. And that's typically how the data is separated for like pulmonary hypertension is long-term pulmonary hypertension patients are able to accommodate. We see dilated right ventricles, but they're much thicker as well. They've kind of become accustomed to contracting against high pressures compared to someone with an acute pulmonary embolism, where the right ventricle has essentially an acute precipitant of high pressure that it's not able to deal with at all. So not only the degree of change, but also the acuity. Okay. And this is helpful from a clinical perspective. This helped me a lot as a resident kind of understand why people with right ventricular failure are so sick. And when I think about left ventricular failure and pump dysfunction, I think about end organ perfusion. And I really think about like the map or the blood pressure that the end organs are seeing, the kidneys and the liver are seeing. And right ventricle tends to be a little bit more unique in that end organ perfusion is really dictated by not only blood pressure or your mean arterial pressure, but also the CVP. And so it's that difference in gradient that's going to essentially dictate oxygen delivery to the kidneys and the liver. And so in right ventricular failure, you tend to have an acute rise or a disproportionate rise in your right-sided filling pressures. And so patients with right ventricular failure tend to have this kind of double hit hypothesis in terms of their perfusion. And so not only do they have a low mean arterial pressure for the reasons we outlined below, but also their CVP is very high, and that markedly reduces end organ perfusion. So it's very common for us to see these patients have marked kidney dysfunction, liver dysfunction, a lot of hemometabolic alterations that lead to worsening acid-base status and further deterioration in the clinical status of the patient. And so now that we have kind of understood right ventricular kind of hemodynamics, anatomy, and physiology, the next step and the difficult part is kind of trying to understand what happens when we put in a device, because the physiology essentially changes in these patients. And with putting in an Impella, you're going to get reduction in left-sided filling pressures. You're putting in a motor, it's going to suck out all the blood from the left ventricle, and you're going to get reduced filling pressure on the left side. That is going to be translated to the pulmonary system, and you're going to get reduced pressures, which the right ventricle is going to enjoy. But then the right ventricle is going to start dealing with different hemodynamics that it's really not used to, and it's kind of unique in patients on isolated left ventricular support. So there's going to be increased venous return because you're essentially providing an entire motor that provides your circulatory support, and so you get increased venous return or preload to the right ventricle, which, as we discussed, normally in a completely normal ventricle, it can accommodate that. But also, because you're reducing the left ventricular pressure so much, you actually change the geometry of the septum, and the septum is now moving leftward. And so with leftward movement of the septum and kind of sucking down, the right ventricle, which relies on that septum for contractility, can run into issues with its function. So to summarize, with putting in an isolated left ventricular support device, you get more blood flow to the right ventricle, and it can predispose it to worse contractility. And so you can see that in a right ventricle that may be affected by the underlying condition, let's say it's an ischemic heart, if the right ventricle is involved, or if it's a non-ischemic cardiomyopathy where the same process that's impacting the left ventricle is impacting the right ventricle, in a vulnerable right ventricle, putting in just a left-sided support system can actually be harmful to the right ventricle. And the degree that it can adapt is kind of variable. And so, again, with increased venous return, you can get RV dilatation and consequent worsening TR, but you can also get compromised RV contraction. Does that make some sense? Yeah? Okay. And so this is just to kind of imagine in your brain, and it was hard to find a video that actually showed the Impella, but if you have these hemodynamic consequences, you have an Impella sitting in the left ventricle here, if your right ventricle is squished over, you can imagine that you can actually then run into problems with the impella support. And so what problems do we run into? Well, we run into problems with what we call suction events. And so the left ventricle is trying to suck blood from the left ventricle. And if the right ventricle is not providing enough blood flow to the left ventricle because it's not able to contract as much, or if it's actually physically bowing into the left ventricle more because now the pressure on the right side is higher than the pressure on the left side, we run into suction events. So this is what it looks like on the Impella machine. You have your arterial waveform, which is essentially an arterial line, and then the white line is going to be your systolic and diastolic pressures in the actual left ventricle. And what this shows is essentially, it shows that there's an uncoupling here where the end diastolic pressures in the left ventricle are very low. They're reading as negative because the impella is sucking onto the muscular wall of the LV, and you're not getting like any flow, essentially. And not only is that bad for the obvious reasons of the machine not working, but we know that patients that are supported with an impella that have some degree of right heart failure do much, much, much worse. And so the survival is worse, increased suction alarms, increased morbidity, and much lower survival. And the thing is that right ventricular involvement in patients that may be candidates for these devices is not uncommon. It's usually present in about 30 to 40% of presentations. And specifically, the complications that can arise is that if you imagine the impella sucking down on the left ventricle, not only is that going to diminish flow, but also you just get like chewing up of your red blood cells. You get hemolysis that leads to acute kidney injury and bleeding and all these types of complications.
Mike, is there a sweet spot on the impella in terms of how much flow the speed you're setting it at? So if you set it too high, you get this problem, but if you set it a bit lower, it actually works? Yeah,
definitely. There's a lot of like clinical variables that you can try to alter to set yourself up for success, and definitely the motor speed is one of them. And so if you're flowing if you're over supporting someone or flowing them too high, you could be sucking down essentially too much. And so sometimes just turning down the speed can help with the situation. The other thing that we tend to do is support the right ventricle medically. So optimizing fluid status, making sure there's enough preload there, which is typically guided by pulmonary catheter. Also using like milnirone, dobutamine, fixing any rhythm issues. All of your kind of supportive strategies for the right ventricle can kind of help temporize this problem. And what I'll say, the next point is that it's important to identify people that are really not going to do well on an impella early on, because we know that like staged escalation of support, like, oh, let's just try an impella and see, and if it doesn't work, is much, much worse than just escalating to biventricular support. And so we know that doing things in a sequential basis is much less effective, and early identifying a patient that is not going to be a candidate for impella due to right ventricular dysfunction and going to ECMO instead, where we just bypass the heart.
Another question, is the echo used to help guide some of these decisions?
Yeah, I'm getting to that. Because this is an echo talk. I haven't forgotten.
That's the key question.
Yes, I haven't forgotten. Yeah. Now the literature on that, as you can, I mean, I feel like I was a bit naive coming into this topic being like, oh, there's going to be a lot of literature to help us guide this. Spoiler alert, there's no literature. But we'll try our best. Okay. And so, because it's already 8:30, I'll kind of go through this quickly, but this is just kind of a quick overview of the most recent ACE guidelines for right ventricular assessment. The point I wanted to make here is that obviously the right ventricle is assessed in multiple views. We don't just look at one view, so you really have to look at the entire geometry of the right ventricle. Typical or indices that we look at and what's been quoted in the literature for patients on mechanical support is the linear dimensions of the right ventricle, specifically looking at actually comparative ratios between the end diastolic right ventricular dimension compared to the left ventricular, because again, that septum becomes very important. So as opposed to the absolute size of the right ventricle, the ratio is actually what's quoted in the literature. These are just tips and tricks how to look at the right ventricle, which I don't need to tell anyone in this room. Probably just need to remind myself more than anything else. And so making sure that you're on axis with your forward chamber so you don't overestimate the right ventricular size is important. This is described in the new ACE guidelines for assessment of the RV, which looks to actually quantify septal shift. Oftentimes, I remember when I was reading echo, we just kind of look at the septum, we're like, it's probably squashed. In diastole, maybe a bit of systole, maybe a bit of both. But this is a quantitative measure that can be used, and essentially it looks at the diameter, both anterior, posterior, and septal laterally, and provides a ratio to see how much it is squashed, essentially, and can say if it's abnormal or not, and looking at both systole and diastole. So,
At a few sessions at ESC kind of went into this.
Touched on this, yeah.
Yeah.
It's called the eccentricity index for anyone that's interested in looking at it. But it can help provide like more of a quantitative interpretation of septal flattening, whereas traditionally I find that we do rely a lot on visual interpretation of the septum. Tried and true, we have our TAPC, our S prime, and then our fractional area change is kind of becoming more into vogue. The point I want to make about the TAPC and the S prime is that in patients on mechanical support or those that are very sick or on a lot of medications, the TAPC and the S prime can sometimes be a little bit overestimated actually, because the only thing that's moving is the annulus. They're on like rocket fuel essentially, and the only thing that's moving is the annulus trying to squash down as much as possible. And so, you know, a patient with a normal TAPC but on like 0.5 milneuron and 0.2 of levofed is very different from a patient with a normal TAPC that's not really on any support. And so sometimes we can be fooled a little bit with the TAPC and the S prime in this specific patient population. Theoretically, the fractional area change is supposed to provide a more comprehensive global assessment of RV function, because it's not only looking at the longitudinal contraction, but also kind of rotation and everything. But as you can probably imagine, practically getting good views of the right ventricle in someone who's so darn sick and has a device in them and you can't put them on their left side and they're supine and they have dressings is a whole kind of different story.
The issue of foreshortening and trying to find the true endocardial regulations makes it really challenging. It's really...
Yeah, exactly. Strain is also another kind of similar technique which has similar limitations. We'll get into some of the literature on that. And actually in mechanical devices, it's strained by TE, so we can see the right ventricle better. It's actually by TE, it's not by transthoracic.
Or anesthesiologists like RV strain.
Yeah. I find actually when I did my fellowship at Toronto General, fractional area change and strain was done a lot in the OR. Not necessarily preemptively, but in the OR with TE, just because of the limitations I want. One interesting concept in the ACE guidelines, and also comes up in literature, is this ratio of TAPC to RVSP. And so essentially this is a marker of right ventricle and pulmonary artery coupling. And so it tells us essentially how robustly the right ventricle is contracting compared to the pulmonary pressures that it's generating. And so you can imagine that if the right ventricle isn't contracting very well, or the TAPC is low, but the pulmonary pressures are high for whatever reason, that is a bad situation to be in, because you get uncoupling of your right ventricle. Normally you want them together, right? The right ventricle is generating a lot of contractile force. The pulmonary pressures are mostly driven by how much the right ventricle is pumping and that's what we call coupling. But if those two markers go away from each other and you get uncoupling, this can be a marker that is essentially dynamic for right ventricular dysfunction, because it's telling us that the right ventricle is not contracting very well, but the pulmonary pressures are high. Most of this literature is in pulmonary hypertension, admittedly.
And that's that marker has been studied in all, like a lot of valvular tricuspid regurg. It's this RVP company, like these lots of papers.
Yeah. Well, I'll kind of mention this at the end, but it's thought to be useful because it's like, it gives you almost a marker of like right ventricular contractile reserve, how it responds to the pulmonary pressures. Like if the pulmonary pressures go lower and your TAPSE, your right ventricular function, gets much better, that is useful to know, because when you put in a mechanical support device, you're trying to mimic that situation, right? You're reducing your left-sided pressures and your pulmonary pressures. So if the right ventricle can almost like rise to the challenge, that is kind of a helpful parameter to know. Just other kind of echocardiographic considerations for temporary mechanical support and other red flags, which I think was covered mostly in the June session, is that you have to make sure that the ventricle is big enough. So if you have a little lady with a tiny left ventricle, they're not going to do very well with an Impella, because you're going to get lots of suction events just because the left ventricle is already small to begin with. Similarly, if you have very redundant cords, myxomatous valve disease, asymmetric septal hypertrophy, those patients are going to run into more problems. If you have a thrombus, you can't put in an Impella. Significant aortic regurgitation will just lead to auto circulation of the same blood, right? It's just going to go forward and backwards. Not very useful for patient perfusion. Severe AS, there's like case reports, so you can stick it through a tiny orifice, probably not recommended. And then you can't put it through a mechanical valve. Reasons. Okay, so when I tried to look at the literature for patients that essentially, or predictive factors for who's definitely not going to do well with an Impella, I thought it was probably best to start with our largest cohort. So the DANGER trial, which many of the cardiology fellows and staff know, was this seminal trial published in the last year or so, which was the first randomized trial which took patients with ischemic cardiogenic shock and basically said standard care versus an Impella. And it was the first trial that actually showed a difference. I won't get into the specifics of the trial, but essentially there was a survival benefit for patients being supported with Impella. And so their exclusion criteria, where they looked at patients echocardiographically and said, no way, you're not getting an Impella because of RV dysfunction, was actually pretty liberal. It's mostly based on the RV size. So if the RV was greater than the LV, if the TAPSE was less than 10, or if there was clear evidence of a septal shift, those patients were taken out. If we look at actual predictors, the only evidence in my fairly exhaustive search is really just for patients being supported for PCI. So we put in an Impella to offload the LV to try to support high-risk PCI. That was the only literature that I could find that essentially looked at risk predictors for RV dysfunction. And it was really the tried and true kind of measurements that held up weight with producing, with trying to predict RV dysfunction. So it was the TAPSE and the S prime in particular, kind of at their typical cutoffs of 17 and 9.5. You can see in the bottom of the screen here, there was like kind of more of a linear relationship with both the TAPSE and the S wave, where if they were worse, the mortality or the risk was worse, whereas the FAC kind of went a little bit up and down, probably due to imaging issues and things like that. Now, when we now transition to durable mechanical support, evaluation of the right ventricle shifts a little bit in these patients because it is the major kind of leading complication for patients that are transitioned to a more durable support. So yes, these patients can go home. Yes, they can kind of live their usual life with this machine, but the most common complication is actually that the right ventricle either fails acutely or it fails over time. And so there's been lots of work in trying to predict patients that respond positively to these interventions. I will say that there is a new device now. It used to be an axial flow pump, HeartMate 2 heart-wear device. And then the last 5 to 10 years or so, there's a new device called HeartMate 3. And there was a very positive trial called the Momentum 3 trial, which showed that strokes and bleeding was much, much lower in this new pump. And so this is kind of taken off like wildfire. It's much more common that we put these in, much more common in the States that they put these in. So it will become more common kind of over the next 20 years, I imagine. Similar red flags, which I won't get into. One that's kind of interesting is if these patients have a PFO or an ASC, you have to close those because you can imagine that you're really reducing your left-sided pressure. So if you do have an interatrial shunt, these patients can start shunting right to left, essentially, and you get hypoxia. Early right ventricular failure is really defined in the first 30 days after implant and tends to have significant impact on patient survival as also more mortality and morbidity. But it's so difficult to study because it's not just how the right ventricle looks going into the OR. There's so many like patient and intraoperative characteristics that essentially dictate how the right ventricle is going to look coming out of the OR. So there's multiple risk scores. Probably the best score is the Euromax score. And actually there's data at Toronto General that looked at all these risk scores and advocated for this one kind of as the best score. And when we talk about late ventricular failure, this is after the patient leaves the hospital, typically defined as after 30 days. And we know that in patients that develop right ventricular failure, they have a much worse quality of life, functional capacity, which is really what we're trying to gain with the LVAD more so than anything else. So it becomes an important, as opposed to early RV failure, where it's typically intraoperative problems. The pathophysiology of late ventricular failure is because of chronic decoupling, which we kind of talked about, but also the underlying kind of natural progression of the disease. So if it's a non-ischemic cardiomyopathy or even ischemic, the right ventricle just becomes involved over time just because of natural progression of the disease. And so kind of going back to early right ventricular failure, you can imagine that it's the similar kind of injuries that occur with an LVAD postoperatively, but there's all these perioperative effects. These patients are going on to cardiopulmonary bypass, they get ischemic, they get hypotensive, they tend to bleed a lot, so they get a ton of blood products, volume, and all of these put a lot of stress on the right ventricle. And so there's been a couple of meta-analysis and literature reviews which look at trying to essentially look at risk provided. So I won't talk about all the invasive hemodynamics, patient characteristics, and blood work, although that's obviously important when you look at the patient as a whole. The things that echocardiographically tend to portend the most risk are moderate to severe RV dysfunction. No kidding. They just define that as visually looking at the RV and kind of characterizing RV dysfunction. But what tended to hold up the most was the RV-LV diameter ratio, had the highest odds ratio. I think it was 2.58. So looking at that discrepancy between the actual sizes of the ventricle tended to hold up the most as a risk predictor. And then RV free wall strain was in there. It was a very, very small study and only under esophageal echo guidance. It was not transthoracic.
Like the RV-LV diameter was off the apical 4.
That one was off the apical 4, yeah. And so this was the study that specifically looked at the ratio between the left ventricle and the right ventricle.
Oh, the apical 4 versus partial long axis.
Yeah.
Yeah. Oh, sorry.
Yes. Sorry. Yes.
So it's not the LV dimension of the apical 4. It's it's interesting.
Yeah. So they compared two different parameters. Yeah. So I guess you traditionally measure the LV diameter. Yeah.
Yeah, makes sense.
And so that ratio,
because it's not the ratio by the simultaneous image, but
yeah, it's not the same image. Yeah.
Yeah. Okay.
And so that ratio difference tended to predict a significant difference in event-free survival, essentially.
But why they do that? Is there any reason why they
two different views? I wonder if it's just because This is traditionally where things are measured.
It's
Like,
probably traditional because the RV dimensions normally in parallel
Yeah.
axis and
Or, you're right, you can do LB and RV on both of them. You get the RVOT instead of the
no,
base
no potential.
on the peristernal.
Yeah.
And
It's more like a
obviously,
database research where they already have those measured.
in probably, yeah.
Oh, yeah, that's right.
Because
Yeah.
we don't normally measure that.
Because our standard RV dimension is of the RV focus view.
Yeah.
So that maybe that's why it is.
Yeah, you're probably right. It was probably just all retrospective and measuring.
Yeah. But it's interesting how just such a simple measure can have such powerful prognostication, right?
Yeah,
It's a very simple measure.
yeah. And this is in the acute phase. And then when we look at long-term phase, the thing that holds up the most is still the RV size, more so than anything else. And so RV size, the annular dimension of 41 tends to have the most positive predictive value for late stage. And the thought is, again, if you go in with an already dilated ventricle, usually that's because of chronic remodeling over time and kind of represents more chronicity of RV pathology. And so going in with an already dilated right ventricle leads to more right-sided problems long-term. Okay, I'll finish with kind of novel strategies to risk stratify. And we kind of talked about this earlier on in the presentation just because it came up. But what's starting to be used is essentially more so hemodynamic assessment with a pulmonary artery catheter, but hemodynamic assessment specifically with like almost stress testing these patients. So doing dynamic hemodynamic assessments. And you can see that Susanna Mack is on this paper here. And essentially what we're looking for is with using medications such as nitroprusside, which we commonly use in the ICU to reduce left ventricular pressure and reduce pulmonary pressure as a consequence, you kind of see like what happens to the right ventricle. Does it stay the same or does it improve? And basically we're trying to mimic what would happen with putting someone on isolated left ventricular support with medications and seeing what happens to the right ventricle. Because the idea is that if the right ventricle kind of stays the same, despite trying to optimize the left, then you don't have as much confidence with if the right ventricle kind of whips into shape and becomes much more contractile, is able to generate higher systolic pressures with changing those. Now, admittedly, like all of the data on this is hemodynamics, which makes sense because hemodynamics with a pulmonary artery catheter can kind of track these changes in real time as opposed to echo. And it's essentially creates this concept of a right ventricular reserve index or contractile index. Now, I found one paper in 2021 that did this echocardiographically. And essentially, actually, sorry, they did not do the echocardiographic. But the only paper that I found that looked at temporary support was where they actually put in an Impella and looked at the hemodynamics. So they put in an Impella to predict patients that would do okay with an LVAD. And so they essentially stressed them with an Impella and looked at their right ventricular hemodynamics and how they responded. But moving into the future with the kind of more common practice of POCUS and regular echocardiographic guidance, this may be an avenue to explore to see the dimensions of the right ventricle, how it changes with offloading. Does the right ventricle shrink or does it stay the same size? Can kind of maybe give you an indication of chronicity and how it will respond to these type of diseases. And these are references. Happy to take any questions?
Well, thank you, Mike. This is actually very well attended online. There was about 75 different simultaneous login today. So it's like a topic that we don't usually think about this too often unless you're actually working in the hospital. And I think many of my colleagues who go to CDICU as well as MSICU. Those are the images actually that we need to figure it out. And in our hospital, we do have ECMO and what else do we have? We have Impella here. We do not have LVAD in this hospital. I think it's only at Toronto General where they have it. But then again, it's being spread to more and more hospitals within Ontario. So your RV assessment is very important. Your LV assessment is very important. The septum is important, and so imaging the RV has always been challenging. So I think advocating for our cardiology residents as well as echo fellows to review the latest right heart paper that was just published, I think, about 2 months ago.
Yeah,
roughly. So I think that's worthwhile to review that again.
It's very comprehensive. Yeah,
it's new, and I heard about all the development from what our trusted friends and colleague Dr. Lawrence Rusky about the whole development in the last few years. I get to hear about this every now and then when I run into him. It's a lot of work that was.